I'm excited to introduce Michelle Larkin, who is the Associate Executive Vice President at the Robert Wood Johnson Foundation. And Michelle is also the board chair for Grantmakers in Health. At the Robert Wood Johnson Foundation, Michelle directs all program and administrative activities of the foundation's program portfolios. And before joining the foundation, Michelle worked as an oncology nurse at the University of Maryland Medical System. And she also worked at the Centers for Disease Control and Prevention Office of Smoking and Health as a Presidential Management Fellow. And she received her law degree from Seton Hall University School of Law, a master's degree in nursing and health policy from the University of Maryland, and a bachelor's degree in nursing from the University of Pennsylvania. Michelle has been a great guide as I've been getting settled into my role here at Grantmakers in Health, and looking forward to working with her and the rest of the board members in the years to come as we move forward in implementing our strategic plan. Michelle?
It's a pleasure to be here with everyone today, and it's been a pleasure to work with Kara over the last 18 months since she came into her role, and I hope everyone, as we work our way through the pandemic and start to get back to being in person with each other and being able to break bread and establish good relationships with each other, that we all have that opportunity to meet Kara, and that we as board members have an opportunity to meet with our funding partners and reconnect with folks we've known for many years, and connect with new people to the philanthropic sector, and make those relationships so that we can build on the field of health philanthropy together as we move forward. On behalf of the board of Grantmakers in Health and its president and CEO, Kara James, and the staff, I want to welcome you again to the 8th Lauren Leroy Health Policy Lecture. As Kara said, I'm Michelle Larkin, Associate Executive Vice President of the Robert Wood Johnson Foundation, and I have the honor of serving as the chair of the Grantmakers in Health Board. GIH established the Lauren Leroy Health Policy Lecture Series in honor of its former president and CEO, Lauren Leroy, and her commitment to increasing communication between the worlds of philanthropy and policy. The series is supported by grants from Blue Shield of California Foundation, the California Endowment, California Healthcare Foundation, California Wellness Foundation, Colorado Health Foundation, Kaiser Permanente, Missouri Foundation for Health, the New York State Health Foundation, and Robert Wood Johnson Foundation. And today's lecture features Dr. Alice Chen. Dr. Chen is the Chief Medical Officer at Covered California, the state's health insurance marketplace, which actively works to ensure that Californians can afford high quality coverage. In this role, Dr. Chen is responsible for healthcare strategy focused on quality, equity, and delivery system transformation, with the goal of improving health services provided through Covered California's contracted health plans in service of improving access and outcomes for all Californians. Prior to joining Covered California, Dr. Chen served as Deputy Secretary for Policy and Planning and Chief of Clinical Affairs for the California Health and Human Services Agency. She led many of the agency's signature health policy initiatives on affordability and access, and played a leadership role in the state's response to the COVID-19 pandemic in the areas of strategic reopening, hospital surge planning, equity, data analytics, and therapeutics. As you can tell, she has been extremely busy. That's in addition to publishing over 50 chapters. And you can read more about her in the hub for the Fall Forum. And she's a graduate of Yale University, Stanford University's Medical School, and Harvard School of Public Health, and an alumna of the Commonwealth Fund, Harvard University's Fellowship in Minority Health Policy, and the Soros Physician Advocacy Fellowship, and the California Healthcare Foundation's Leadership Program, and Aspen Institute's Health Innovators Fellowship. So we are thrilled that Dr. Chen could join us today, and we are looking forward to her lecture. So thank you, and I'm going to turn it over to Dr. Chen now to deliver the Lauren Leroy speech. Thank you so much.
Thank you so much, Michelle. I wish I were in person so I could have jumped in to curtail that intro, because that's definitely not the focus. Let's see here.
You've done a lot of work, Dr. Chen, and it's good to have a moment to be able to celebrate it. In particular, we as women, I love to read a bio like that. So thank you so much for sharing with us and spending time with us today.
Thank you. It really is a pleasure. And I have to do my disclaimer that I really wish we were in person. I don't think I'm ever going to get used to talking into the void. So I think let's see. There we go. Okay. I would like to spend my time with you reflecting on healthcare reform. This is actually a nice compliment to Ara's comments earlier, what we've achieved and where we need to go, particularly in the context of COVID. I am somebody who believes that while the arc of the moral universe is long, it does bend towards justice. I'm just not sure that the arc of healthcare will get to health without some serious intervention. It's been a long time since I worked in philanthropy, but I've always felt that it has a unique role to play as catalyst in nudging that arc and addressing society's most pressing problems, which in healthcare, as you know, are many and longstanding, and as Kara mentioned, have been really amplified by COVID, which has been devastating, particularly for communities of color. At the same time, if there's a silver lining to COVID, it's that it's created an opening to talk about the profound racial and economic inequalities in our country. So when I think of the trajectory of healthcare reform, I think of these two triangles. Back in the 90s, when I first got interested in health policy, I was taught about the iron triangle, which is the idea that access, quality, cost, you can't have all three, pick two. If you want to control costs, then you have to compromise on quality or access. If you want to improve quality, costs go up or access goes down. But then people started looking around the outside the United States and realized we were actually the exception. No other industrialized country had so many uninsured. We spend 50% more than the next highest spending country. And that despite spending so much, our outcomes are at best comparable, in many ways much worse, particularly in measurements that truly matter, like life expectancy and infant mortality. So the question is, if everyone else is doing better, how can this be an ironclad rule? And in 2008, the Institute for Healthcare Improvement introduced the concept of the triple aim, which really turned this concept inside out. Not only are these things not mutually exclusive, we have to aim for all three things simultaneously: better access and experience of care, better population health, and I would include addressing disparities there, at lower costs. And so the triple aim, some people call it the quadruple aim now, along with clinician attention to clinician burnout, but the triple aim really remains the overarching framework for healthcare reform. So how have we done? The one area we have definitely made progress in is coverage, although frankly, for many of us who have been in this for a while, it's been painstakingly slow, and we're still not at universal coverage. In many ways, our modern healthcare system starts in 1965, when Medicare and Medicaid were signed into law. And you see here a precipitous drop in the uninsured. You see another significant drop after the Affordable Care Act was passed, with Medicaid expansion and creation of the marketplaces like Covered California in 2014. What is actually most remarkable is the part of the graph that you don't see because I couldn't find it, but between 2015 and 2020, despite COVID and huge rates of unemployment, the rate of the uninsured did not appreciably increase. The ACA has been a resounding success in serving as that buffer and safety net for Americans during the biggest stress test to our society in modern times. And I just want to pause for a second because, you know, when I first started in healthcare, my career, I spent many years in the safety net, and Medicaid was considered a niche program. At this point, Medicaid covers more people than Medicare. 1 in 5 Americans, in my state, California, 1 in 3 Californians, 40% of kids, 50% of births, more than 60% of nursing home residents. So this has really become a central part of our healthcare system, and it's really critical for equity. The marketplaces have also been really critical part of the safety net for people who make just too much to qualify for Medicaid, and who don't have affordable employer-based insurance. With the American Rescue Plan that Kara had referenced, we've seen significant increases in enrollment with over 12 million covered now. So the main work to be done here is those 12 states that haven't yet expanded Medicaid. So that's the good news. What's the not so good news? So we're an absolute outlier among all other industrialized countries in terms of how much we spend on healthcare, now approaching 18% of GDP. Not only does that divert resources from all other social goods, and it doesn't really matter where you are on the political spectrum. You're talking about parks, schools, fire, police, roads, whatever else you care about outside of healthcare. It's also made healthcare increasingly unaffordable for Americans, even when they are insured. Over the past decade, healthcare costs have risen at more than twice the rate of wages. And as these prices have risen, insurance premium has skyrocketed. Employers then shift the cost to employees in the form of higher premiums and deductibles. And in many surveys, healthcare costs are top of mind for many Americans. And it would be one thing if we were getting value out of all that spend. So I want to be really clear. This is not to say that we haven't had tremendous life-saving and transformative advances in biomedical treatments for heart disease, cancer, HIV. Just look at the COVID vaccines. But on a population health front, it's not so rosy. No matter how you measure it, we haven't improved much despite our increased coverage and spend. So the graph on the left shows trends in healthcare quality that are relevant to population health, like primary and preventive care. Over the course of a decade, you've seen there's really been no significant improvement. More disturbingly, when you look at hard outcome measures like life expectancy at birth on the right, we again are an outlier, and again, not in a positive direction. So we're that black line at the very bottom that's starting to really diverge from other industrialized countries. We also know that single line for life expectancy doesn't tell the whole story. I am sure you've all seen the data on how our zip code is more predictive of life expectancy than our genetic code. I'm sure you've seen the maps of the various public transit systems and how life expectancy is radically different at different stops. Insofar as life expectancy is impacted by disparities in healthcare quality, we haven't made much progress there either. So the graph on the right is from AHRQ, the Agency for Healthcare Research and Quality, and it shows the progress or lack thereof for measures that at baseline had racial and ethnic disparities in the year 2000, compared with the latest data available, which is anywhere between 2013 and 2017. And you can see that out of 182 measures, the good news is that only 3 worsened, but only 14 improved over that time period. So in terms of what we've achieved with healthcare reform, while we've made important and tangible progress on coverage, we have persistent problems with affordability, outcomes, and disparities. If we want to achieve the triple aim, we have to think differently. Or we need to act on what we already know. So it's been accepted for quite some time that healthcare plays a relatively small role in preventing death and creating health, somewhere between 10 and 20%, depending on the study. The problem is that knowledge really hasn't been turned to action, perhaps because it's been hard to know what to do with it. So this graph is really powerful because I think it gives us some clues about what we might do. It's from Betsy Bradley's book, The American Healthcare Paradox. And the premise of the book really is to answer the question that was posed by the data we just reviewed. How can we as a country spend so much money on healthcare and yet get so little for it? And her insight was that we have been looking for our keys under the healthcare lamppost. If we broaden the lens to look at both healthcare spend, which are the blue bars, and we are an outlier, and social services spend, which are the red bars, we actually are no longer an outlier. We're in the middle of the pack. The key difference is that we have differing priorities than other countries. For other OECD countries, for every dollar they spend on healthcare, they generally spend $2 on social services. For every dollar we spend on healthcare, we spend less than 60 cents on social services. So her work is really called the question, how do we need to invest for health? And the truth is, we have some of the answers already, and we have had them for some time. On the left is Jack Geiger, who helped start the community health center movement in 1965. He and Count Gibson went to Bolivar County, which was one of the poorest counties in the United States, 80% unemployment, widespread hunger, and not coincidentally, more than 2/3 Black. They built a clinic, yes, but they also engaged in community organizing, dug sanitation wells, and planted vegetable gardens. And he wrote prescriptions for food. Which sounds familiar given all the health-related social needs work now. And when they were challenged on this, Geiger famously said, the last time I looked in my textbook, the specific therapy for malnutrition was food. On the right is Unlock Senior Health Services, which is another model organization. That was founded in the 1970s in response to the needs of frail, poor, elderly Chinese immigrants at risk for institutionalization. In the 1980s, long before there were Medicare Advantage plans, they went to HCFA, CMS's predecessor, to ask for capitated payments for their Medicare Medicaid patients. And their holistic, community-oriented, multidisciplinary, team-based care model was funded by RWJ to be spread as what's now known as the PACE model, the Program of All-Inclusive Care for the Elderly. And full disclosure, my first job out of college was at Unlock, and I can say from firsthand experience that its model is very different from traditional healthcare. So this slide I can skim over because Ara actually covered this in great depth. But sadly, you know, these models, FQHCs, the PACE model have been around for many years, but they're far from the norm. And, you know, I talked previously about the coverage provisions of the ACA, but there was a big focus on payment and delivery system reform. You've heard about CMMI, you know, over the first 10 years, launched more than 50 different payment models involving almost 30 million patients. It has been very transformative, and I think I'm not speaking out of turn by saying, you know, Ara, Liz, the folks at CMMI have been stepping back to really reassess its approach, which had been more along the lines of 1,000 flowers blooming, and really trying to focus in on how do we achieve these goals. Ara mentioned equity, and to that end, new models will require collection of demographic data, as well as data on social needs and social determinants of health. I will say, as a practicing clinician, if there's one thing that healthcare system is good at, it's creating codes to capture data, particularly if it's for payment. We now have Z codes that capture factors that influence health outside the healthcare system. That is a really good thing. We're even at the point where we're able to parse out different types of homelessness and different degrees of poverty. Medicare plans are now allowed to offer special supplemental benefits, including things like gym memberships, medically tailored meals, transportation assistance. In several states, including North Carolina and California, have waivers that are focused on covering health-related social needs. Whether it's a focus on food, housing, transportation, the work in this area really has grown exponentially, and it's from multiple perspectives. You've got hospitals and health systems, you've got payers, you've got physicians, even embedding these issues into clinical guidelines. And what I would say is that this increased interest and dialogue is absolutely a positive development, and it is a long overdue recognition that health happens outside the four walls of a clinic or hospital. But I do worry that we've gotten a little sloppy about how we think and talk about social determinants of health. Because this is how the WHO defines social determinants of health. They are the conditions in which people are born, grow, live, work, and age. And they're shaped by the distribution of money, power, and resources. If you haven't read this blog, I would really encourage you to take 5 or 10 minutes to do it. And the point is that providing fresh fruits and vegetables for my 57-year-old African-American patient with diabetes who I saw in my clinic 2 weeks ago, which my clinic does, and which is a very good thing, does not change the fact that he grew up eating potatoes, corn, and canned green beans as his only vegetables, that he's never tasted broccoli or eggplant or celery, and frankly, at his age, has no interest in trying them. And he lives in a neighborhood that has no grocery stores. He has a corner store with ratty lettuce and old tomatoes. So let's not confuse giving him groceries when he comes to see me, which again, really important and supportive of his health, with living in a food desert and the policies that are required to change that. Because words matter. When we conflate our work on health-related social needs with social determinants of health, it obfuscates the issues. Frankly, it lets us off the hook and it prevents us from understanding what we need to change at what level. Which is a good segue to talking about what is arguably the single biggest social determinant of health, poverty and income inequality. We hear statistics all the time about the poverty rate. It is the unfortunate yardstick by which we measure eligibility for most of our safety net programs in this country, but people are often shocked when they register what being at the poverty level actually means. So I can't see any of you right now, but I'm gonna do the honor system. I want us all to pause for a moment and write down, or at least hold in your head, how much money you as a single adult would have to make in order not to be considered poor. So I'm gonna let you think about it for 3 seconds. In 2021, if you live in the continental US and make more than $12,880, you are not considered poor. For a family of 4, it's $26,500. And in reality, we all know that you can make twice that and still struggle to make ends meet in many parts of America. As a country, in fact, we've stood out for some time among our peers. You're starting to get the pattern here for our high rates of poverty and income inequality. So much so that in 2017, the UN Special Monitor for Extreme Poverty and Human Rights, who every year chooses a country to highlight, not in a good way, chose the United States. And it should be noted that even as we were singled out, the poverty rate was actually declining. In 2019, the poverty rate was 10.5%, which was the lowest rate on record since the government started keeping track. Of course, COVID changed that overnight, wiped out 2 years of gains. And you can see here that not only are our poverty rates above 10%, but they're significantly higher, almost double for children and many communities of color. And it's not just about poverty, but also about income and wealth inequality. This is certainly not unique to the United States. This graph shows the share of national income in Western Europe that belong to the bottom 50% in blue, that's the top line, and the top 1% in red, and that's the bottom line. And you can see that over the course of 35 years, the top 1% has gone up by about 2%, while the bottom half has decreased by about the same amount. Contrast that with the United States, which was more unequal to start with, but now the top 1% account for more than 20% of income, and the bottom 50% about 13%. And if you were to look at this graph by wealth, it would be even more pronounced. So I'm going to do another pause. Guess how much the bottom 40% of Americans own in terms of our country's wealth. Just have a number in your head. It's 0.3%. 0.3% of wealth for the lowest 40%, poorest 40% of Americans. And the pandemic has really only added fuel to the fire. When COVID first started, I was working at the agency, and some call it the great equalizer. Everyone is at risk for infection, and we now know that it is, in fact, the great divider, the great accelerator. This is a graph of employment rates by income, and you can see that while all groups were affected initially, the recession has really largely been invisible to wealthier individuals who have experienced a rebound not only in the job market, but in the stock market and in home equity. It's impossible to talk about poverty and wealth inequality in the United States without talking about the policies that have racialized and reified poverty for African Americans in particular. We think about slavery, Reconstruction, Jim Crow as historical, but the tail of those policies are long, and some have evolved into new forms that very much continue to shape reality today. So this is a map of San Francisco that was commissioned by the Federal Home Loan Bank Board. These were called residential security maps, and they were developed for 239 cities across the nation. And you can see how explicit they were in using race to demarcate in red, the term redlining, the neighborhoods that were seen as too risky and therefore ineligible for federally insured home loans. So this excluded African Americans from home ownership and generational wealth creation that's had really lasting repercussions. You can see that the original map is not so different from this recent map of school performance or from this map of preventable hospitalizations, which is really one of a dozen that I could show you that show the same distribution geographically. So in a very tangible way, race is tied to place, poverty, and health. In many ways, COVID has been, sadly, a perfect case study for this interplay between race, place, poverty, and health, and also reinforces that pie chart we saw earlier, where healthcare has a relatively small contribution to population health outcomes. So let's walk through this. So in the context of COVID, clinical care, it's ICUs, oxygen, steroids, monoclonals, and more recently, vaccines. Health behaviors certainly play a significant role: masking, physical distancing, gathering outdoors, and now decisions about whether to get vaccinated. But those behaviors are very much shaped and constrained by social and economic factors, like whether you were able to telework, whether you lived in the suburbs in a big house with your nuclear family, and whether you had ready access to testing and care. In terms of the physical environment, there was a big difference if you could drive in your own car versus having to carpool, and what kinds of protections your workplace provided. And of course, it was communities of color that were disproportionately impacted, more likely to be essential workers, living in crowded multi-generational households, taking public transit to unsafe workplaces with less access to care. So very much a perfect storm. And the results have been both utterly predictable and still shocking. The pandemic played out slightly differently in different parts of the country, but overall, African American, Native American, Latinx, and Pacific Islander American communities have really borne the brunt of disease and death. Here in California, Latinx communities make up 40% of the population, 60% of the cases, and 50% of the deaths. This was pre-vaccination, and that was skewed to a younger age group than the general population. While COVID has resulted in the loss of more than a full year of life expectancy for the country, for Blacks, it's more than 3 years, and for Latinx communities, almost 4. So this is the thing. We cannot address these massive disparities by looking for our keys only under the healthcare lamppost. We have to broaden our scope and connect the dots between our social policies and health policies. And again, as with much in healthcare, this is not a new idea, but it has particular relevance now. And I think that philanthropy has a role to play in amplifying this message, finding the synergies, and connecting the dots. And the great thing is there are dots there to be connected. So the American Rescue Plan that was passed earlier this year had many important healthcare provisions related to both COVID and coverage. It is one of the reasons why we didn't see a big blip in the uninsured with COVID. But arguably, some of its most important health provisions were around poverty reduction and improving food insecurity. Similarly, the Infrastructure and Jobs Act, which will be signed, I think probably still will be signed, I'm not sure what time, today has provisions that, while not labeled health, are incredibly important to health equity. So broadband investments to bridge the digital divide for poor, rural, and urban areas to enable telehealth, removing lead from pipes, improving water infrastructure for tribal communities, investing in public transportation, which so many poor communities rely on, and environmental cleanup, which is frankly environmental justice. It was frankly shocking to me in reading through some of the supporting materials that according to the EPA, more than 1 in 4 Black and Latinx Americans live within 3 miles of a Superfund site. And then on the right, is the current state. Who knows where it will end up, of the Build Back Better Act. It has, again, explicit and critical healthcare provisions in the form of Medicaid and marketplace subsidies and support, Medicare hearing benefits, in-home support services. And if you step back, universal preschool, child tax credits, investment in affordable housing are long-term investments in health that are likely more important in closing that gap in population health outcomes that we saw when we were comparing ourselves to other countries. So we have the resources and knowledge. The question is whether we have the will to not only embrace value-based payments in healthcare that address disparities and drivers of health, but also to think where we invest as a society and how to be intentional about the connections between healthcare and social services. If there is one image I'd like you to remember from this talk, it's Betsy Bradley's graph on the left. And the graph on the right is actually an exemplar of how this plays out. So the red line is the budget for CMS over the course of nearly 5 decades, compared to the budget of the Housing Urban Development HUD in green. You can see how they diverge. You can see how this is a reflection of our different priorities compared with other industrialized countries. The answer, I would argue, is not for us to grow the CMS budget to pay for housing through Medicare and Medicaid, but figure out how we over time shift the spend from CMS to HUD. So I will leave you with one of my very favorite quotes from FDR. The test of our progress is not whether we add more to the abundance of those who have much, but rather whether we provide enough for those who have too little. I think often of Uwe Reinhardt, who in the context of concierge medicine was saying, you know, why pay attention to concierge medicine? In the United States, we have concierge everything: housing, healthcare, education. What we should be focused on is the floor. How do we make sure we have a safety net and continue to raise that safety net up to support every American? And I'll leave you with some last thoughts, which is our current focus on identifying and addressing social needs is absolutely necessary and completely insufficient. We really need to resist the temptation to own it all, to funnel everything through healthcare, and to medicalize poverty and social resource needs. The last thing we want is to parse out who deserves food versus who doesn't based on their diagnoses. And then I would just ask you, do we have the commitment as a society to health, not just provision of healthcare services, but do we have a commitment to health that would logically result in over time figuring out how do we shift money away from healthcare into services that would really truly accelerate health for our communities. And I will end there.
Thank you so much.
Thank you, Alice, for that wonderful presentation. And I think that, you know, you've really laid a challenge for us in thinking about how we address those bigger issues that are really driving a lot of what we're seeing. You know, this is really a health funders audience. And so when you're looking at the maps and the graphs and figures that you showed, and we think about how we help to shift some of that funding streams that are, you know, really dedicated to healthcare payment and policy, what recommendations would you have for the role that health funders could play in helping to move forward, understanding that many of them are in a lot of these spaces already, but if there was your top 3 things maybe that you think we should do?
You know, I really think of health policy as the image that comes to my mind is, you know, those keychains you make in camp when you're a kid, the 4 plastic strands, and how you need to weave them together, and you have to pull all 4 of them in order to layer on and actually grow the keychain. I mean, I think that there is a role for philanthropy in policy and advocacy, in evaluation, proof of concept of programmatic investments. And actually, I think in this area in particular, community engagement. I think we live in a very polarized and fractious society right now. And yet, when you talk to pretty much anybody in any community, everyone wants the same things for their children, for their communities. And it's not more healthcare, it is health. And so some of the most promising things I see are engaging deeply in community, serving as that catalyst in glue. For example, in North Carolina, with their investment in health, bringing together different stakeholders. And importantly, I would say healthcare should not be the leader. In the same way that ACOs that are led by hospitals don't do as well as ACOs led by, clinicians. I think community engagement needs to be led by someone other than the healthcare system in addressing health-related social needs, but healthcare has to be at the table. So I think philanthropy has a really promising role, big and small, across the country in catalyzing these discussions and roundtables and engagement, because ultimately, and this is a phrase that really came to mind during COVID, is change happens at the speed of trust. And right now we don't have a lot of trust at the national level. I think we could build trust at the micro and meso level and figure out how do we bring the two ends together.
Thank you for that. And again, thank you so much for providing this year's Lauren Leroy Health Policy Lecture. We are really grateful that you took some time to be with us today.